This week on the BackTable podcast.
I feel in my experience, and I don't know if you see this in LA, Sid, is my patients, it takes a long time for my patients to get a transplant.
I'm assuming that all the UNOS regions are different, right? So ours, at least in LA County, is terrible. I would say once someone gets MELD exception points, we're looking at 3 years. I know that varies across the country.
I'm going to get in trouble, Sid, by asking you to send your patients down south to San Diego. Forgive me, Vachiagopian, but
I know where to send my patients.
We're not seeing that. We're being very deliberate and intentional about approaching those patients. As John said, when you're a transplant surgeon and a hepatobiliary surgeon, you keep both options on the table, and I think it's really useful to have both options available because different situations, and there's a lot of cases that are on the margin that could go either way. And if you have a 3-year waiting time, there's no question that those marginal cases should go to resection, right?
Welcome to BackTable Tumor Board, your source for the latest on multidisciplinary cancer care.
We're going to be talking about surgical approaches to HCC, and I have got an awesome panel of surgeon and IR here. Can we get everyone to introduce themselves? We'll start with Sid Padia.
So I'm Sid Padia. I'm not a surgeon, so I have no idea how to do a surgical approach to HCC. I'm an interventional radiologist at UCLA.
Gabe Schnickel. I'm a transplant and hepatobiliary surgeon at UC San Diego.
And I'm John Seal. I'm a transplant and hepatobiliary surgeon at Ochsner Clinic in New Orleans.
Great. And I'm Sabeen Dhand, your moderator today. And let's just start off with what is the definition of curative and palliative? Okay. It can be a gray zone. So what exactly does it mean to you, Gabe?
Sure. I think curative, in medicine and certainly in surgery, we always talk about measure everything in years. So I think once you get out to the 5-year mark, I think everyone kind of looks at that as being curative. So when we approach surgery, we think about it as a curative approach versus palliative, where your intent is to clear and leave the patient with no evidence of disease.
Y90 is considered palliative to most, Sid. Why is that?
I agree with you, but that's not the approach. I don't disagree with those definitions because that's, I think, probably the more widely accepted definitions. I don't end up using those in my practice, particularly in the HCC population, because anytime we say cure, these patients assume they're never getting another cancer again. And unlike every other cancer, a woman has breast cancer who doesn't have a family history of breast cancer. She gets a lumpectomy, radiation. Her risk of getting breast cancer again is 1 in 11, just like the baseline population. The risk of someone with alcohol-induced cirrhosis, we know that there's a good likelihood they'll get a new cancer. So when I started saying you're cured, and then they're like, well, why do I need Q3-month imaging? And then they don't follow up with me, and they're like, well, I got another tumor. It's in the other side of the liver. It has nothing to do with what we did or the surgeon did. So I got burned in the beginning. And so I've just kind of rephrased the way I've interacted with patients. And I basically say that tumor is dead or forever, right? But there's always risk of new ones. So I've used that because I've unfortunately miscommunicated the word cure to patients.
Yeah, I never use it. That terminology, I don't know, do you all even use those terms with it? I never do. So, I think it's like, it's all a process to optimize the treatment options.
But do you use it for transplant, though? That's the one time I say, okay, look, the real ultimate cure is getting a transplant, even though it's not
but
zero. It's not zero, but it's so low.
Or 8
right?
or whatever. It's 8. But it's just that I would hate, because what are you going to tell them they're cured, and then you're going to tell them you have to get a scan every 6 months.
Right. Okay, yeah. It's like, why? Why am I getting a scan? Right.
Yeah. It's good news when you get the transplant, but is it cured? I'm kind of delicate about that word turn. I'm also very delicate about palliative care. You come in with a 18-centimeter tumor. We probably all have a case or two where there have been a great response. So I'm not going to say all the stuff we're doing up front is palliative out of the gates. So it's an interesting question, but I avoid both.
It's
same.
Come up sometimes where someone's like, do an ablation or something that's curative versus,
But there's conversation within the medical community, let's say the 4 of us, and then there's a different understanding with patients, right, of what cure means or palliation means. When the lay public or a patient hears the word palliation, they think you are not treating them and you're just going to give them a bunch of oxycodone to treat their pain, right? Like that's what palliation means. And so I think we need to be careful about like what we discuss with each other is very different than what we discuss with patients because their understanding is very different than what I might come to understand.
Yeah. And we kind of just said it earlier where transplant is the goal, right? We want to get to transplant. Now, the surgical approaches include resection and transplant. When do you decide just a resection only and the patient's not going to go to transplant? What are different things in your treatment strategy that select resection over transplant?
Yeah, I think there's some variability between practitioners. I'd be interested in how Gabe approaches this. There's really a lot of factors. The first is really the extent of the underlying liver disease, right? So you've got someone with no cirrhosis, de novo tumor that's clearly resectable. Those are the ones where, I think resection is a really good option. Anytime a tumor occurs in the context of cirrhosis, you have to kind of physiologically think in your brain, there's a lot of damaged liver cells there, and there's going to be an increased risk that they're going to form new tumors in the future. But you have to balance how you're going to approach that with what that risk will eat. I mean, transplant's not a free ride, right? So even if you want to get to transplant, you would hate to put them through a massive operation when you could have cured it with a little wedge resection or something like that. And then you have to look at the overall health of the patient. There are patients who transplant is not an option, and those we kind of push the envelope on resection a little bit more. You look at a number of factors that sort of dictate how big that operation is going to be and how you expect the patient will recover. And that metric has shifted a lot as the less invasive tools become a lot better. The things that you're achieving with Y90 are really comparable to the outcomes of resection in a lot of cases. And I think we have to think long and hard before we start operating on cirrhotic livers and doing big cases when there's a safer option with similar outcome.
And Gabe, what would be, different types of surgical approaches as far as what are different resections for our listeners? What's a triseg? What's anatomical, non-anatomical?
I think that's a great question. And I think when I think about who should get a resection and who should get a transplant, as John was saying, you have to think about the status of the underlying liver and then how much liver remnant, what's the future remnant going to be? And so when we think about the extent of resection, just for definition, you have your anatomic resection. So when you're taking out an actual segment of liver that is based on the vascular anatomy, if you're taking out a whole, what we might call a lobe or like a hemihepatectomy, which would be either the right hemiliver or the left hemiliver, or you're doing a triseg, as you said, which means you're doing an extended hepatectomy. You're taking out all of the right and some of the left liver. Those operations for HCC are tricky because, again, most of these patients will have some underlying liver disease. I think it's around 80%, right, of patients with HCC will have cirrhosis. And those that don't might have some baseline underlying, whether it's fatty liver disease or they have hepatitis B or whatnot. Those are all considerations that we have to keep in mind. As John said, it's really evolved over, the past couple of decades, when we think about transplant and when we think about resection.
And you talked about FLR a little bit, the future liver remnant. Sid, are you doing many things to increase FLR in the setting of surgical resection?
By FLR, you're meaning like a radiation lobectomy, right, to hypertrophy the other side. What we have seen over the last, let's say, 5 years when we started doing radiation lobectomy at UCLA, we did them for, I would say, predominantly two indications. Number one is HCC. Number two is metastatic colorectal cancer. For HCC, I would say that our results have not been as great as we and our hepatobiliary surgeons had hoped for. I think there is still this issue of, as you said, there's 80% of them have underlying cirrhosis. The ones where we have done a successful radiation lobectomy, for them to get it to a curative intent surgical resection, it hasn't been as promising as we had hoped. Same thing with portal vein embolization. It's, you do that portal vein embolization to get FLR hypertrophy in the HCC patient. They go to the operating room, there's too much cirrhosis, the tumor grew, et cetera. So that's also a problem. In the CRC population, it's been a little bit different. And so what we've kind of done is much more of a, I would staged and much more patient approach in terms of doing, let's say, a radiation lobectomy with the intent of future liver hypertrophy, but we don't necessarily always go to surgery anymore. Go to surgery if there's certain risk factors, high AFP, there's a risk of them progressing. But there's a good proportion of patients where our surgeons have chosen to kind of leave alone and just do kind of a watchful wait.
So is that after, the plan is for surgery, and then after the local therapy,
after the local therapy, let's say we restage, and let's say you get a complete response and everything looks good, patient feels great. The question from our surgeons is, does this patient need a right hepatectomy? I don't know if we know the right answer to that. I think in the non-aggressive tumors, and if it looks good, and let's say, as you mentioned, the risk factors are a little high for a surgical resection. Let's say they're 80. Let's say maybe they're not ECOG 0, they're ECOG 1, where your complication rate may be slightly higher than baseline. Should we just hold off on those patients and see what their biology does? And is it possible that they may never need one?
And I feel like we're getting the answer to that question. It's really hard to do prospective trials, right, in surgery.
It's almost impossible.
So we're not even going to touch that.
Almost impossible.
But
yeah.
I think probably several of us here have a cohort of patients we have in mind that we know they can't be transplanted and they're not great surgical candidates. We're like, we're just going to do radiation therapy, and we watch them, and then 3 years later, you're seeing them in clinic. You're like, that worked well for this patient in this context. So now when I have it in a patient where maybe there are some other options that aren't totally straightforward, it might give me a little hesitation to dive in and do the triseg on that patient, and maybe I'm not really helping them if I do that. Plus, after y'all get to these livers, it's not super fun.
It's not easy.
To go down the middle vein, right? When you get all those radiation changes, and it increases the risk of biliary complications. So kind of the surgery post, depending on the time frame, right? Longer out, the bigger the issue is. But that can make cutting into the liver pretty tricky.
Would you argue also the exact opposite? Let's say you did a radiation lobectomy and you got great hypertrophy, and let's say I got great hypertrophy, but not a home run on the tumor. I got partial response. Would that push you then go, you know what, maybe this person, I'll push the limits, right? Like I'll push the limits in terms of resection. I might actually, maybe they're a higher risk because they're 78 years old, but it's worth it.
Yeah, you have to take it case by case, for sure, yeah.
Yeah, I think, just the fact that you see hypertrophy, the data shows that the liver is actually going to respond and regenerate afterwards. And that patient's probably more likely to tolerate a major resection. So it's really helpful to see that response, and that would give me a little bit more courage to step up in that marginal case and be willing to do the bigger resection for that patient.
With the inverse being true and equally important, like, oh, you did all that and it didn't grow?
Yeah, we should have definitely done
cut it out?
Right.
That's a booby trap. I'm not going for that.
So I had one 6 months ago, radiation lobectomy. He was 79 years old. Procedure went great, no technical issues. I got a complete response. He got moderate ascites. So our hepatobiliary surgeons, there's no way I'm doing a right hepatectomy if you got ascites. Now, his ascites went away after 6 months, but he said, there's no way I'm doing a right hepatectomy on this guy if you got ascites after a radioembolization.
So you're kind of the canary in the coal mine in that situation, right? You're the one testing the waters to see if that liver is going to tolerate it. So thank you.
Yeah, the patient was upset. The patient was upset at me, not the hepatobiliary surgeon for the ascites. Yeah, exactly.
Took one for the team, Sid. Thank you.
Yeah, thanks, Sid. What are some more characteristics when you look from a surgical perspective? Say someone's presenting a case at tumor board. What are a lot of the patient characteristics that you look for that will make it a surgical candidate?
Yeah, there are a number of things. Obviously, we have to always reference that the background is the extent of the cirrhosis, right? Okay. And I think that as access and outcomes in transplant get better and better, then more of these people with advanced liver disease are just going to go straight to transplant. At least that's what I've seen in my practice over 10 years. I'm kind of leaning more into transplant for a lot of these cases. The size of the lesion and location of the lesion in a relatively healthy liver, I think, dictate that a lot. A lot of progression with minimally invasive approaches really changes the recovery and the type of patients you can do these on. So for lesions that are relatively small and on the periphery of the liver, those are the ones that I don't hesitate to do robotically, and those patients go home in 1 to 3 days. And you can do that in the context of a much sicker patient. In bigger patients, we see a lot of obesity in the part of the country where we practice, and that becomes a really important tool if you can do it robotically or laparoscopically. If it's really central and you have to take out a lot of healthy liver to get one little tumor, then that gives me a little bit of pause of like, maybe I'm not going to take out 70% of your liver for a 3 centimeter lesion, knowing what y'all can do with kind of regional approaches. That's kind of my take, Gabe.
Yeah, no, I agree with your sentiments exactly. I think for me, it's evolved over time. I'm much more leaning into transplant in saving resection for either patients that are not cirrhotic or just very minimal Child's A cirrhotic with a lesion that's really more on the periphery, where I'm not having to take the full right lobe. I'm really reluctant to do that, and I'll push them more towards transplant. The reality is, as we have evolved over the past 5 years, there are more livers available now, and I think the hesitation to save those donor livers for more patients, I think that's kind of shifting. And honestly, we don't have a lot of HCC patients on our list. They don't stay very long because we transplant them so quickly. So I think definitely as the outcomes are getting better with transplant, leaning more towards transplant in general.
I think it's only fair to do a little bit of disclosure here that you invited a couple Swiss Army knives here, right? Because so we can kind of put both hats on. And that's how we think about it in our practice.
Sure.
I think there are a lot of other contexts where, a patient's seeing a surgeon who is a resectionist and doesn't do transplants, and they're going to maybe think about that a little bit differently, and they may lean into surgery a little bit more. I think the most important thing to think about in those contexts is to always engage with the decision-making in a multidisciplinary setting so that you really get the perspectives from a lot of different people and that all options are being considered at each step of the patient's treatment.
It's interesting that you mentioned that these HCC patients are getting transplants quickly. I feel in my experience, and I don't know if you see this in LA, Sid, is my patients, it takes a long time for my patients to get a transplant.
I'm assuming that all the UNOS regions are different, right? So ours, at least in LA County, is terrible. I would say once someone gets MELD exception points, we're looking at 3 years. And, I know that varies across the country.
I'm going to get in trouble, Sid, by asking you to send your patients down south to San Diego. Forgive me, Vachegopian, but
I know where to send my patients.
But we're not seeing that, and we're being very deliberate and intentional about approaching those patients. So I know that's kind of, as John said, when you're a transplant surgeon and a hepatobiliary surgeon, you keep both options on the table, and I think it's really useful to have both options available because, different situations, and there's a lot of cases that are on the margin. So I would be interested to hear what John thinks. Cases that are on the margin that could go either way, and if you have a 3-year waiting time, there's no question that those marginal cases should go to resection, right? But if you have a waiting time of 6 months or 7 months, then, it's the intention to treat, when the clock starts that makes all the difference.
I mean, how much variability is there as far as transplant criteria? Is it very strict, Milan and UNOS, or what are we talking about? Because sometimes I don't know whether I could send this patient for a transplant or not. Is it variable?
Yeah, it's not variable in the sense that all of deceased donor organ transplantation is governed by UNOS, which is a national organization, and they regulate how donors are approached, how organs are shared between centers, and it's based on how high the MELD score it is. It was discovered pretty early on in this process that there's lots of people who have cancer who have a real risk of death with cancer, and it's not reflected in how sick their liver is, so with the MELD score. So that's where the exception point process came into play. So people who get listed for transplant have an HCC that's within the Milan criteria, then they can, after a 6-month waiting period, get exception points, and they fall into that median MELD score for a region. It gets really complicated, but basically that's what it means, -3. So a little bit below the average of where that is. And as we're suggesting, depending on where that is in the country, that turnover at the top can be so fast that if you're sitting below the average, then you're not ever going to get there. So that's one factor. The other is you can take slightly larger tumors and you can shrink them and then get the exception points. But all that process is going to be dependent upon waiting for those exception points to kick in. And that largely dictates how long you wait, with the exception of, and all that I said there is about deceased donors.
Okay,
the caveat is really living donors, and we can touch on that and how that changes your decision.
No, let's touch on that because in the Los Angeles area, there's not many options for living donors, but that seems to be different in your area?
Well, that's the strategy that our center is leaning into now. So with a living donor, we take if the patient has a potential donor that's healthy, and there's a pretty strict criteria. You have to be pretty healthy to put someone through this operation. Donor safety is always number one priority, and we're very careful about doing this. But if you have a donor, then we remove the right lobe of that liver, and then we take that piece and we transplant that. And it's an operation that you have complete control of if you have a living donor, because you know when that's going to happen. You know, all the medical care can be optimized, all the treatment can be optimized. It's really important when we're not doing this today, but really important for cholangiocarcinoma, because they get blasted with radiation, and if they sit on the list for 3 years, then that's game over. Like you can't do that. So you basically don't have to play by the rules if you have a living donor, and you can get people transplanted really quickly. That way, not everyone has it, not everyone does it, but it's an important option.
How about around here in San Diego?
We do living donor as well down in San Diego, and I think that's a great option, as John mentioned. But we've also kind of leaned into the use of machine perfusion and normothermic regional perfusion to access livers that previously were not being used for transplant. With that, we've been able to make more organs available for our patients on our list and transplant at a much lower MELD. So those patients that have HCC get a nice set exception points on our list, and we're able to actually transplant them pretty quickly. And so we really leaned into that, and that's really definitely shifted, at least from my perspective, leaning again on those marginal cases. Either our waiting time after they get their points, so at 6 months after listing, it's less than 3 months until they get transplanted. So that allows us to lean into transplant for marginal cases where if your wait time is 3 years, and I think the literature bears this out, you're certainly at risk of tumor progression and falling off the list, despite, SID's best efforts. And, we're really reliant on the IOs, interventionalists, to maintain those patients on the list and to keep them from progressing and falling off the list because their tumor gets outside of the Milan criteria that John mentioned.
Sid, do you find any trouble with...
I mean, as you said, it's hard, right? Because, when I see a patient, I make the assumption, whether it's right or wrong, this guy's never getting a transplant, right? Mm-hmm. So I play to that. Mm-hmm. If he gets a transplant, great, I didn't lose anything. But I make the assumption that he's never going to get one. So what I do is I play for okay, what do I need to do in terms of a local regional therapy standpoint, whether it's do nothing, do an ablation, do a taste, do a Y90, send them for an SBRT, et cetera, to get you the most number of years possible, make with the assumption that somehow you're not going to get a transplant, even if you are eligible. You may not get an organ, you may start drinking again, you may lose your insurance, you may have family issues, you may move out of state, et cetera, right? We've had all those patients we thought they were transplant candidates and they just, it didn't happen for them, right? So it becomes tough, not necessarily on day one, but to plan the next treatment for when they get inevitably the next tumor, right? So that's what we try to do now, is play that long game. This is where concepts like radiation segmentectomy came about. This is where we're very aggressive on our thermal ablations. This is why chemoembolization has largely fallen out of favor, I think, not only at our place, but I would argue at most transplant centers, because chemoembolization works great within the first 6 months. But then when we look at the recurrence rates at 12 and 24 and 36 months, there's a very real recurrence rate. It's fine if you're going to get a transplant in 6 months, in a way. It's not fine if I'm playing the long game of 36 months or 48 months and finding these recurrences, and then I have to come up with a plan B.
On the other side of the situation, and what comes up in my clinic a lot, is a patient who doesn't want surgery. That's an option, and they're like, oh, no, doctor's too much. It's too big of a surgery. I'd want the minimally invasive option. How do you approach those patients, Gabe?
Yeah, that's a great question. I think it's really incumbent on the surgeons, and I'd be interested to see John's opinion on this, really to put all the options on the table. And I think it's really those options have shifted over time to the point where, when it comes to, okay, you can have a resection that's going to be, for me, an open surgery, or you can go to interventional radiology. They're going to give you a tear or radiation segmentectomy that's going to be really a durable option for them. That's really probably not that different than what I'm going to accomplish. And in that patient population that doesn't want a big surgery or, for whatever reason, or perhaps their functional status isn't great, it's really a legitimate, it's hard for me to say that surgery is the right answer for them, whereas it used to be, I feel like, pretty clear cut that was the gold standard.
But at the same time, Sabeen, as an interventional radiologist, if I have a patient who goes, I don't want surgery, actually what more happens, I don't want chemo, right? Like that's like 99% of people, right?
Lucky for you, you got the one cancer that
exactly. Yeah. But let's say they say, there's no way I'm getting cut open, et cetera. What I'd like to do is I'll be like, I'm going to have you meet with our guys, right? Just meet with my hepatobiliary surgeons. Let them talk to you about it. If you still don't want it, fine. It's still your choice because they can describe it way better than I can. And they can also, weigh the risks and benefits way better for a surgical resection or a transplant 100 times better than I can, especially when our surgeons, just like you guys, individualize it for each person. They'll be like, okay, based on your specific risk factors, you're a disaster and you don't want surgery, or the exact opposite. They can do that. I'm not very good at that when it comes to surgery, right? So I tell patients, just have a conversation with them. You're not buying into anything. You just have to have a conversation with our surgeons, and then you can make it's still, at the end of the day, it's still your decision.
And John, you mentioned a robotic approach to surgery. Now, does that increase the amount of patient selection that you have and more patients are...
It hasn't really increased the number. It really has to do with that sort of algorithm I described loosely before, which is if you've got, I do left-sided liver resections robotically. Okay. I'm not quite a Gen Z, so like all the kids coming out of residency, they do robot everything, and I have to teach them how to make an incision. And so that's how that goes. I feel comfortable doing all the left side. So anything that shows up on the left side, that's really, I think it's safe to do that robotically. And in some people's hands, even trisegmentectomies and big operations are really safe. So again, I think one of the themes we're picking up on is every part of the country, every set of providers has a little niche of how they've adapted to their local environment and how they're trying to take care of their patients. If you have a jet and infinite amount of money, then I know where to send you, and the person's going to do the most aggressive robotic surgery out there. But if you want to stay at home, then it's like, oh, this is what I'm comfortable doing. The reality is, I don't know if this is true for you, we used to do god-awful incisions for surgeries.
Yeah.
I do all liver resections through a little
Mercedes
midline.
line.
Yeah,
Chevron,
we still do. Anyway, that's a sore subject. Our practice is still that for the transplant, but for a liver resection, it's a midline incision, and the recovery is really quick, and it isn't as morbid as patients often think, but the indications for it are shifting. And for a patient who has something that we can do robotically, the recovery is really, really fast. So it's a great tool to have for the right patient.
Got it. We touched on downstaging and bridging a little bit. Sid, are all your patients getting bridged to surgery per se, or
surgery or transplant? Either one, you're saying?
Yeah, either one.
So if someone comes in with an HCC, they're getting, if they're a good surgical candidate, they very well may get surgical resection. And just like all of you guys, we have a multidisciplinary tumor board. It is quite collaborative. Of course, nowadays it's all web-based and not in person for the last since March of 2020, right? And I don't know if it's ever going to go back. But so if someone is a good surgical candidate, they're going to go straight to a surgical resection. And if someone is a good transplant candidate, they are going to get bridged with some form of local regional therapy to get to an eventual OLT. And how they get bridged is, I would still say, a matter of debate. Our practice, we typically lean on a percutaneous thermal ablation or radioembolization. Those are kind of our two main weapons that I would say we use in 98 to 99% of the cases.
Same in your institutions too?
Yeah, I definitely moved towards Y90 pretty substantially. I think, we really liked microwave for a while because we thought it was really more durable. Like you're going to get a longer treatment effect. And then there was the data on taste than thermal ablation. But now it's really, far and away, it's Y90 at our institution for sure. And that's the bridge and the downstage. Downstaging for, is almost always going to involve some Y90 because obviously that tumor burden is pretty high, and the response is going to be probably more significant with a Y90.
And John, you mentioned, I always thought that the Y90 helps with the resection, but you said that it can actually make the surgery more difficult.
It's funny. This came up in another session. If you're in surgery to cut out cancer, then it helped. It got you to be there to cut out cancer, right? So in that sense, it did.
From the technical
So
sense.
from the technical sense, I mean, it depends how crazy you get, but a really aggressive segmentectomy causes a lot of scarring, whether it's a resection or transplant. And, it's not something I want to complain about because it means someone's there and they're getting this treatment. And I don't know, it's very rarely like a big deal, right? It's just
something to think about.
Annoying.
I had to create a dot phrase called on-block diaphragm resection, thanks to the Y90.
There you go. Dome.
So back in, so we did our first radiation segmentectomy in 2011. And this was when I was at University of Washington. It was segment 7 tumor right up against the IVC. 7 or 8 months later, patient gets a liver transplant. Liver transplant was done typically, 3:30 a.m., right?
Yeah, sure. Not anymore, but right.
But at that time, right? Now you guys have better preservation techniques, right?
Yeah.
And the surgeon calls me, who was amazing and wonderful person, and calls me at 3:30 in the morning, just dropping F-bombs, going, "What have you done here?" Right? And the challenge of the segment 7, it was adherent to the IVC. He had no, and this is the first time they're going into a patient who had gotten a radiation segmentectomy and was completely stuck, and the IVC tore, and massive blood loss. Patient did fine, fortunately, but that was their first experience with it, and I agree. I mean, we've at 2 different institutions, the surgeons, in my experience, especially tell me what you guys think, certain specific locations are worse than others, right? Like what I've noticed anecdotally, again, I'm not the one in the operating room, the ones near the IVC where you're causing the right hepatic lobe or the caudate to get stuck to the IVC, or the ones in the porta hepatis. Like those seem to be the kind of the sore points for you guys.
Yeah, the diaphragm, I mean, it's not a huge deal because taking out part of the diaphragm is not that troublesome. In the stomach, like the left one that gets the stomach stuck up there, that's really annoying. Yeah. It's more annoying, and we probably, I'm sure, the surgeons have taken your name in vain several times.
Fine, no problem.
But again, to second John's point, you got them there. So
got them to the surgery.
Yeah, that's what matters.
The times where it's really if you have Y90 radiation changes plus XYZ, that's when it gets tricky. So if you have really bad portal hypertension and really bad varices and a bunch of adhesions from Y90, that can be a little bit of a bloodbath. But fortunately, anesthesia has also improved over the past 30 years, and they can usually keep up, and there's a lot of things you can do to temporize that. And then we deal with really extreme obesity, and that when you're trying a really, really deep hole and you're trying
that's a bad combination.
That's not fun too.
Do you think it's also experience-based in the fact that, just to be more specific, the more you guys resect patients who have had prior radioembolization, the easier it gets, or let's just say the less challenging it gets?
I think you come to the OR more prepared. As I said, I created that dot phrase, but now I don't try and get it off the diaphragm anymore. I just plan to take the diaphragm with it, and so that saves me a lot of grief, a lot of headaches.
Okay.
So you just know what to expect, and it makes things easier. And you know why it's stuck there. You're like, Sid was here. Great, thanks, Sid.
Yeah,
I know. Sid, you think of any techniques that we should be aware about or something to try helping our surgeons out with this?
No, I mean, it's a double-edged sword, right? Because you want to get them to the OR, right?
Yeah.
If you're talking about a surgical resection or a transplant. So every time I've thought about this, and again, with our wait time, do I do a chemoembolization, which may have, we don't actually know this, which may have a lower adhesion risk, but then the recurrence rate at 9 to 12 months is 50%. I'm not really cool with that, right? I'd rather get them with some adhesions, and then when they explant the liver, there's no active tumor. I think that's a better end result. So we've just bitten the bullet and done it that way.
I mean, the elephant in the room is the wait time, and if you can do that pretty quickly, then those radiation changes are usually relatively manageable. I did a transplant last week, a guy who had been treated downstaged over a huge period of time, and those are just... That's when I'm going to get that dot phrase. And you're just like, I just took everything that was attached and I put it in the bucket and I put everything back together.
Okay. What about patients who are referred to you from the community? I'm talking from personal experience too. How do you keep the loop in those, those physicians in the community, the oncologist, the operator? How do you keep like a full loop going that everyone knows what's going on? Or does the patient really just get into your center and then the care gets taken care of over there?
From my perspective, it's a little bit tricky. I think that could always do a better job communicating. I might get a patient that comes to my cancer clinic, and then I see that, this is actually a patient better served by transplant. And then I'll present them to our tumor board, and then they, kind of go from there. I'll connect them with hepatology, and then they kind of get, sucked into the system. And once you get into the transplant system, then, we kind of take over. And I'm sure some, community physicians get a little bit, put off by the lack of communication, like what happened to that patient I sent you? Am I ever going to see them again? And that's definitely something, at least from my perspective, we could be a little bit more deliberate about. I'm not sure how it works on your end, Sid.
We absolutely, just be honest, suffer from a little bit of arrogance. We're a tertiary care, quaternary care center, honestly similar to where both of you work, right? And the thought, whether it's right or wrong, is that we do it better. I don't necessarily agree with the fact that we do it better. So the challenge is this. I live in West LA. We have, just to be brutally honest, we have referrers who send us patients who've gotten local regional therapy. And when you look at their local regional therapy, it is absolutely exceptional. Okay, it's perfectly done. And then we'll get another one, and it's the exact opposite. And sometimes it's hard to tell like who did what, because I may not know that person.
Yeah, stop talking about me like
Actually,
that.
Ironically, the few patients we've gotten from his center, you look at it, you're like, that's exactly what I would have done. This looks perfect. Okay, so the challenge is, how do you make this blanket policy at UCLA to say they should all return back to the community, because we have gotten burned on that, where centers just don't do it the way we would prefer in terms of a local regional therapy standpoint. So Sabeen, what would you like us to do about that? I can't say, for Sabeen, it's okay to send it back to Sabeen, but for the next doctor, no, we should do this at UCLA. And for doctor number 3, we should do it this way. So that's what it becomes hard for us to do.
Yeah, to be honest, I think it relies on the community doctors to actually start to get to know, you guys and develop a communication, because I don't ever expect, if it's someone I don't know, they're not going to call me. I mean, you guys are busy. But like, if I refer someone to you, Sid, then I'm already talking to you, and I'm talking to other surgeons in your program. So I think it takes from the community side that effort, and then that you can continue the loop of communication.
I would also say, and maybe this is somewhat unique, like if a community, let's say an interventional radiologist, were to contact our hepatobiliary surgeons, Fatty Caldis, Vajay Gopi, and say, hey, look, I got this. How do you guys normally prefer doing this? They would be very open and honest. They would be very conversational about it and not speak from a point of arrogance or bravado, right? Like they would be like, okay, what you're doing is fine. Just keep in touch, right? Here's my email. They'll give you their email address. They'll give you their cell phone number. And they're very easy. Honestly, they're incredibly easy to communicate with. So I would encourage, number one, if you're in the community and you're not at a transplant center, contact your local transplant center. Get in touch with a transplant coordinator. That's probably the easiest intake. And be like, hey, look, can I just set up like a 20-minute Zoom meeting with your guys just so I can get an idea of like what they prefer? You may find a transplant center is like, we hate Y90. We only want our patients getting TACE. So if you start doing Y90, we don't want anything to do with your patients. Or it might be the exact opposite. You don't know, right? Because there's a little bit of personal preference. And you could probably learn a lot by doing that. And it builds relationships between academic and community centers, which I think is sorely needed.
Yeah, no, that's a good point. I mean, feedback from any surgeons, if I ever get it, I mean, it's helpful.
Yeah, again, if you got us to surgery, then that's kind of the bottom line. I think we have to lean a little bit. We don't have anyone at the table here, but we have to lean a little bit into the health systems, right? We have to build them in a way that there can be better integration. We don't have there aren't community transplant surgeons, right?
Yeah, exactly.
It's like, no, this requires this whole behemoth of regulatory stuff, and we only kind of exist in certain places. And so one of the things that we've done is we have sort of not a wide open policy, but because, as you alluded to earlier, we have these virtual tumor boards, right? So we just invite people all over the state, and you can talk to and you present the patient, and we're like, oh, this is what's going on. When you get into not straightforward Y90 cases, we are a little picky because I think you can do that wrong, and we want the best for the patient. But we can have that conversation and figure out how that needs to happen. Also, patients, I don't know how it is. I'm blown away by this. So New Orleans is like 600,000 people, super small. And there's people who live over a bridge. They will not come over the bridge. And you're like, what is going on? I mean, it's the big city. And like, oh, wow, no. So we have to also meet patients where they are. And that's the trend. And we got to work with our partners in those communities to do what they can there.
I love this virtual tumor board idea. This is fantastic. If you can incorporate the community into the tertiary academic center, that's great. I mean,
that's really cool.
That would be.
It requires some tiptoeing because, I mean, I don't know what yours is like, but ours is on a Tuesday morning, and we're already doing like 26 cases.
So how do you have time to add
So we're not ready to like upload that, but it's sort of been like you have a patient that comes and you identify that this provider in this community is looking for better resources. And if we can provide that, and they have 2-3 cases a year that come to us, so it's like, yeah, we can make it easy for you. So we should do better at that. We have lots of tools. We need our administrators to think more creatively about how to connect those dots.
Well, I think that's a good point to close on. That was awesome. Any last remarks?
Yeah, can I run one question by you guys? There's a couple of trials now, and there's medical oncology pushing the limits in terms of bridging or downstaging to OLT with immune checkpoint inhibitors. What are your thoughts on that?
Yeah, that's kind of I feel like part of the next frontier, which is really interesting. We have had, I think we were one of the earlier centers to report some really negative outcomes in patients transplanted after immune therapy. And you have to really tread lightly. I do think it's an important tool that can be used effectively to downstage folks. It shouldn't be used for maintenance, I think, but downstaging potentially. And you have to be very thoughtful about how you transplant them afterwards, because you're completely changing their immune system, and that change is lasts for longer than you think. And the outcomes or the potential for catastrophic outcomes after transplant are significant. And so, you just have to be thoughtful about it. But I'm interested to hear what John's practice and what you think about that is.
Yeah, we're very case by case, and we always like to learn from other people who try things. And so I appreciate those
especially when they fail.
There you go. Yeah. I mean, so much. So at the and this is like such an annoying phrase, but it kind of is true. Like biology is king or queen, however you want to phrase it, right? So what that really is going to do is going to shrink it. The pictures look better. But have we really changed the biology of the tumor? And so for us, that really critical period is that first 3 months off of it, and just to see what the tumor is doing. If we see active tumor biology in a short window off of that immunotherapy, then I don't know that those are great candidates. Because I do think you need that big buffer to get the immune system, the washout period. And, we've learned that too. We are not using it a ton. I think we probably have, 3 or 4 cases a year that we're doing it. And they don't all make it, right? There's also the denominator that doesn't always get reported, which is the people who don't get downstage.
Right.
And no one writes those papers, right? But it's a tool, right? And it's evolving, and it's exciting to have something else, because we have had nothing, right? It's just like cut it out as quick as you can. Like burn it, fry it, and cut it out. It's like, let's be a little less caveman about it.
Well, thank you all for coming and dropping this knowledge.
Awesome.
So thank you.
Right. Yeah, thanks. It was a lot of fun.
Thanks for having us.
Appreciate it.
Bye.
If you enjoyed this episode, go follow or subscribe to BackTable Tumor Board on Spotify, YouTube, or Apple, where you can watch or listen to the full season covering all things HCC. We brought together leading experts in oncology, interventional radiology, hepatology, and hepatobiliary surgery for discussions that matter and to help you level up at your own HCC tumor board. You can keep waiting for each episode in the season to drop Fridays on the VI show, or you can go follow or subscribe to BackTable Tumor Board and get them all, including the full video discussions and tumor board kits reviews on Spotify and YouTube. Enjoy!
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe. rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.